So our next panel discussion is going to be on integrating nutrition and healthcare on food as medicine and food insecurity screenings. So for anyone that is not familiar, we're kind of following a little bit of the path today of the White House Conference on Hunger, Nutrition, and Health on the pillars. So the first pillar was on related to improving food access in community settings. The second one is on nutrition and health. And then later on this morning, we'll be talking about nutrition education. So with that, I'm gonna pass it over to Rachel Ingram, who is going to moderate our next panel.
Hi, good morning, everyone. Thank you so much for joining today's Food Summit. So as Kelly mentioned, I'm going to be speaking on the second pillar of the White House Summit, which is integrating nutrition and health. This pillar prioritizes the role of nutrition and food security and overall health, including disease prevention and management, and ensures that our healthcare system addresses the nutrition needs of all people. At Bronx Health Reach, we are connecting nutrition with healthcare through two different programs. The first is a food insecurity screening program that identifies patients who are experiencing food insecurity and then connects them with food pantries and other available resources in the community. The other is a produce prescription program, which we work on in collaboration with Corbin Health Food Project, and which will be the primary topic of today's discussion. Our panelists today include Dr. Pascale Jean, National Program Leader of USDA National Institute of Food and Agriculture, Dr. Mallory Konings, National Program Leader of USDA National Institute of Food and Agriculture, and Norma Gonzalez, Farm Share Manager at Corbin Health Food Project, whom, as we mentioned, we are fortunate enough to work directly with on the produce prescription program. We are grateful to have our panelists with us today and appreciate their time in discussing these incredibly important topics. If you all could provide a brief summary of your background to the audience, that would be wonderful. Dr. Jean, let's start with you.
Good morning, all, and thank you for the invite. I'm happy to hear the great discussion. As Rachel mentioned, my name is Pascale Jean. I am a national program leader with the USDA, National Institute of Food and Agriculture, in the Institute of Food Safety and Nutrition Division of Nutrition. It's a long speech. But along with Mallory Konings, we co-lead the GUSNIC program. I'm excited to be here with one of our grantees, and Norma. I'm excited to hear all the great work you guys are doing at Corbin Food. And we have a short presentation for you, but just wanted to introduce myself and pass it to Mallory.
Is Dr. Konings on?
Let me check with her because I know we were having VPN issue earlier, so I'll check on her. But Norma, if you don't mind going.
No problem. Hello, everyone. My name is Norma Gonzalez. As Rachel mentioned, I am the program manager at Corbin Hill Food Project and have been with them for now almost 1.5 years. So it's definitely been a wild ride with the Corbin Hill team, a really beautiful and enriching environment where I get to work with amazing organizations, especially Bronx Health Reach, always at my side. So really excited to talk about the Food as Medicine program and the different branches that it has, as well as some of the future initiatives that we're hoping to instill with the with the guidance of our community participants. Because at the foundation of everything we do, we really always try to have community at our heart and at the center of all our programs. So I'll pass it on over to you, Rachel.
Great. Is Dr. Konings there to introduce herself?
She might be, she's trying to log in, so she will join us, but I just want to give a shout out, and we do have another 4K on. Chris, sorry to put you on the spot. Chris Grime is also joining the GUSNIC team, so I just wanted to say he's also a national program leader, and just wanted to make sure that you guys are aware he's also on the call, but she'll join us shortly.
Okay, great. Excellent. So we'll go ahead and get started. So let's move on to the substance of this panel. If Dr. Jean, you could be so kind to present the overview of your program at the USDA, that would be wonderful.
Definitely. I'll be sharing my screen. Can somebody please confirm they're seeing the correct screen and not seeing my notes? Thank you very much. Hello, everyone. As mentioned, my name is Pascale Jean, and I am a national program leader, co-leading the GUSNIP program, also known as the Gus Schumacher Nutrition Incentive Program. Before we get started today, here's a non-discrimination statement that we have to share with you all. But for interest of time, I'll zoom through it. What is GUSNIP? Well, this innovative program was created by the Agriculture Improvement Act of 2018. The 2018 Farm Bill reauthorized the program for fiscal year 2019 to 2023 and was renamed GUSNIP from its previous name, which was the Food and Security Nutrition Incentive, also known as FINI grant program. GUSNIP is a collection of 3 competitive grant programs, which are the Nutrition Incentive Program, the Produce Prescription Program, and the Nutrition Technical Assistant and Evaluation Program. The 3 programs provide incentive to income-eligible consumers to increase the purchase of fruits and vegetables and prescriptions for fresh fruits and vegetables. In addition, the programs support growth in underrepresented communities and geographies, collects and aggregate data to identify and improve best practices on a broad scale. The GUSNIP goals include increasing the purchase of consumption of fruits and vegetables among participant households, reducing individual and household food insecurity, improving health outcomes of participating households, and decreasing associated healthcare use and cost. Now I want to illustrate the GUSNIP reach. This video shows the increase in funded projects by states over each year of GUSNIP funding. The purple states have the Nutrition Incentive projects. The dark green states have the Produce Prescription Project. And the light green states have both the Nutrition Incentive and the Produce Prescription projects. You'll see over time, not only have we increased the reach and coverage of these awards across the US, we have also increased the number of states with both types of awards operating. Here are a couple of numbers to illustrate the growth in GUSNIP over the years. In 2019, there were 22 GUSNIP Nutrition and Produce Prescription Grant Awards. And only just in 2022, there were 182 GUSNIP total awards. As illustrated in the earlier program, GUSNIP is made up of 3 programs. One part of this is known as the GUSNIP NTAE, which is charged with collecting and aggregating data, sharing results like the impact finding report, and sharing best practices and building capacity. Here is the QR code. Please make sure to scan it and access the electronic version of the report. For those of you that don't want to read the full report, there's a short executive summary. I highly recommend you guys scan this code, and we'll bring you to the annual report landing page on the Nutrition Incentive Hub website. I will just share some of the key findings from the year 3 reports. One thing I want to tell you is that GUSNIP is working and is impactful. As you can see, the economic impact has increased tenfold since year 1, demonstrating a significant return on investment from federal funding. Local economic impact can be defined as amount of money generated from communities surrounding the locations offering incentive. And year 3 of the GUSNIP generated an estimate of $85.6 million in local economic impact, which is a 67% attributable to GUSNIP and a 33% attributable to the GUSNIP COVID Relief Fund. Local economic impact helps participants not only afford more fruits and vegetables, but also stimulates the local economy and support local farmers. Now we'll focus on the overview of the Nutrition Incentive Program outcomes from year 3. One of the goals of the program is to all constantly evaluate and make sure that we are meeting our goals. As illustrated here, there were nearly 3,000 food retail outlets, such as grocery stores and farmers markets, that were operating as nutrition incentive sites in year 3, and nearly double the amount which is nearly a double the amount compared to year 2. Nearly $40 million in incentives were redeemed across all nutrition incentive sites. Again, double the amount compared to year 2. With an estimate of 146,000 participants reaching on a monthly basis by the Nutrition Incentive Program. And similar to year 2, year 3 survey found that the longer the participants participated in the Nutrition Incentive Program, is that the longer they are in the program is associated with both not only higher intake of fruits and vegetables, but also increasing their food security. And that's the vast majority of our participants were satisfied with the Nutrition Incentive Program they were participating in. Regarding produce prescription programs, the highlight of it includes that we had over 900 sites for produce prescription project. And these included not only food retail outlet, but also clinics. And these sites are located in communities that are on average approximately 15% below the federal poverty limit. Almost 2 million in incentive or vouchers were redeemed in year 3, and 93% of the participants reported high satisfaction with the program. Enrollment numbers were just under 2,000 new participants each month, and after participation, there was an increase in fruits and vegetables intake and food security among the participants. Collecting healthcare measures can be challenging for many GusNIP grantees, but over half of these projects were collecting some forms of health-related data. Just want to highlight some of those data that were collected. Of the 33 unit produce prescription project awarded in 2019, 58.1% are collecting health and clinical outcomes such as blood pressure or hemoglobin A1C. 45.2% are tracking positive healthcare utilization, so they're going for a well visit, not for a sickness. 25.8% are tracking negative healthcare utilization, like emergency department visits. And more than half are reported having access to participant electronic health records data. Some of the challenges to collecting and evaluating these data exist, and that's across the board for all PPR projects, the Produce Protection Project. There are laws and regulations that protect the patient's data, such as HIPAA, inconsistency on how healthcare system define and record these metrics, a limited knowledge or capacity to apply for RAB approval, and to develop data using aggregate agreement in retrieving the electronic health record data, and a lack of understanding of appropriate healthcare outcomes to measure the various patient population. Although we're sharing this great data, we just want to make sure that there are some challenges. But one of the role of the NTAE, which is the center, is to continue to support all produce prescription projects to overcome these barriers and make progress towards extracting and reporting on participant healthcare costs, their utilization, and outcome data, especially engaging in expert and small grant programs. In summary, the year 3 findings demonstrate continued and collective success, not only in the nutrition incentive, but also the produce prescription project. We see twice the number of incentives distributed and redeemed compared to year 2. We see grantees continue to allocate a large portion of their budget to direct incentive. And most importantly, we see a positive participant outcome in fruits and vegetables intake, food security, and perceived healthcare. Thank you.
Thank you so much, Dr. Jean, for that overview. Norma, if you would like to provide your overview, please try and be brief so we can have time for questions at the end.
All right, thank you. Thank you so much for that, Dr. Pascale. Really appreciate that overview, and so happy to contribute to that work and the cloud of data that's all going together and informing the future of food as medicine program. So again, everybody, thank you so much for hearing the presentation today. Norma Gonzalez, part of Corbin Hill Food Project. I'm going to be talking over I'm going to do an overview of food as medicine program, and specifically about the future of the food system economics. So through Corbin Hill, our main mission is to supply fresh food to those who need it the most, where ultimately we want to have a community-controlled food system that creates wealth for communities of color and low-income people. Now, there's a variety of ways that we get from our mission to our vision, and one of which is our Food as Medicine program. So to give you a little bit of background, we were first awarded with the Nutrition Incentive Grant in 2021, where we initially were going to do a total actually of 6 community clinics with not only Bronx Health Reach as one of our partners, but Mount Sinai. I will tell you a little bit more about how that has changed since, but so far we have 3 community clinics. We were then awarded again in 2022 to receive an innovation grant. This is after seeing some of the issues that many of awardees were facing, community members were facing, that there was a need for additional funding for, to do some tweaks to the initial grant. And that now has expanded our program to include 4 additional sites, all of which are community-based and or residential locations. We had some definitely a wild ride throughout 2021 and 2022 to get everything going, where we really began to reflect, to be completely transparent, because that's how we lead at Corbin Hill. We definitely felt like there was, tension. We were not necessarily always following our mission and vision. And as we all know here, we always have to do a self-reflection as we continue to build out these mass programs. And to be true to that ultimate vision, we did a self-reflection. So throughout that year of self-reflection, as well as other, partner changes, we ended up launching in February 2023 of this year, which not only led to the inception of these said innovations from the actual grant, but also a reestablishment of our mission and vision centering around community power and community advocacy, which we will be hopefully, I will be talking a little bit more about as we progress through our talk today. Now, briefly, our program, the project timeline is about 2 years. We had 6 months of planning, which was a little bit more, as Rachel knows, when we will have 1 year of distribution. Now we have been extended. Our program has been extended to go beyond, where actually that will benefit all the different organizations, because as we started a little bit later than we had first intended, and concluding with a 6-month evaluation. For our program, each participant receives a produce box full of 8 to 10 different produce items, fruit and veggies. This program is distributed every 2 weeks, and our clinics, as well as our residential locations, just take turns in receiving produce boxes throughout the weeks. And we work really closely with not only the providers at those clinic and residential sites, but as well as the site coordinators and other coordinators on the ground to not only have distribution of said produce boxes, but make sure people are, repeat visitors. We're doing constant recruitment with our coordinators, and obviously ensuring that the engaged participants are, getting their produce and providing the data for different surveys, but also contributing to the overall goal of food as medicine programs and beyond. We definitely see this program expanding beyond the 1 year allotted time for both the innovation and the original grant, because we don't see this program stopping. We actually see food as medicine as the current and future of food economics. So that's just a tidbit that we always want to mention, that if you're not in food as medicine, we're actually behind. And to really emphasize, we're actually catching up to our communities, particularly communities of color, who know food has been medicine for centuries, really. these are some of our partners who are involved in our Food as Medicine program. We obviously work with different clinics through Bronx Regional Institute of Family Health, but as well as universities like Lehman College, who is now assisting us in the evaluation process, and Rewire Health as well. We're working with the Fortune Society, Harlem Wellness Center, and Brotherhood Sister Soul, some of which are actually receiving the remaining produce boxes from deliveries where participants aren't able to pick up. And this keeps the food just constantly staying within community and nothing is wasted. So some of the guiding principles for, for our programming, as well as the future of Food as Medicine, is revolving around these different values, principles, and some infrastructure that we want to instill. Some of these I will discuss most likely in some of the questioning that we'll be receiving, but ultimately we see community control and decision-making as fundamental assets of all Food as Medicine programs. We also think community ownership and community wealth building is essential in all of this endeavor, as well as non-extractive community building and community resiliency. We know that the survey process is a general, expectation for so many of our programs. And oftentimes that data leaves communities and never really returns, aside from, different pamphlets or presentations. But what would it mean where communities start owning that said data? And we actually are developing that in partnership with Rewire Health. We also believe in consumer sovereignty and ultimately with the goal in the future to have limited or the absence of charity and poverty governance. And ultimately, at the very end, we want to have a permanent sustainable infrastructure that builds upon community assets, creates local aggregation and distribution systems. And obviously, we really do need to include a re-education of the impact of big food, an introduction of local versus non-local food, and why is it so important to be purchasing locally, where that will definitely influence the community buying power, and also in addition that community data ownership that ultimately we want to have. So that's hopefully that's a brief overview. I'm excited to take any questions. I was limited in what I said because I definitely want to expand upon those different aspects as we progress.
Thank you so much, Dr. Jean and Norma, for your insightful overviews. I'd now like to ask you some questions with the few minutes we have left. So, Dr. Jean, first, this was touched upon earlier, but just for audience members, how does the produce prescription program benefit from the Farm Bill? And do you feel this is a tough one, but I'm going to put it out there anyway. Do you feel there will be similar programs or expansions of programs like this in the future and as a result of the Farm Bill?
As you guys know, as federal employees, we're not privy to anything as far as the Farm Bill. We are in pins and needles like the rest of you all. So we do know, I can tell you from the 2018, it was mandated, so we did implement it. So we are waiting for the 2024 to be released to see what will be there. So I hope you'll be there. There's no indication it won't be there, but we'll see what happens. So unfortunately, I don't have any insight or any additional thing to share that. We're all waiting like all of you guys and can't wait to see what we get to do with the programs.
Thank you. So Norma, this question is for you. Sorry, just make sure you mute yourself if you haven't. Norma, what kind of policy or system changes are needed in order to improve these programs? What are your hopes for the future?
Thank you, Rachel. I think for our program, I could answer in a very easy way where it mainly focuses on Corbin Hill's mission, right? We're thinking about non-extractive community building, obviously community resilience, really focusing on, obviously we need more funding to go to these programs to not only tweak it and change it as we grow and change with the deepening of relationships. That's one lens that I can take. But ultimately, we're just starting to engage in the narrative of food as medicine. We're like the architects who just got their degree and getting started in New York in particular, because one of the innovations we have is our community council that's actually going to launch on Monday. Just to let you know, at one of our community centers, we have a group of individuals who are coming together and really guiding us and for not only the next few months of our programming, but beyond food as medicine. Ultimately, we definitely need to ensure that community members are at the basis of all our programs, from the inception, even all the way to the application process, right at the beginning of the proposal, to the drafting of the actual program, to the implementation and the evaluation. Where when their voices are included, it really centers the work at the grassroots level, where people are actually getting what they need, and it is founded on the assets of that community. We often think about needs and run needs assessment. Oh, there's not enough food here, there's not enough pantries, but ultimately the organizations and communities we work with have so many assets that need to be built upon. And can sustain programs even beyond the funding that we get from USDA or other opportunities. So we definitely see at the most basic level, improved funding, right? But the next one is flexibility to change and alter the programs. And they're not set in stone. Everybody knows here that programs will change even a week after inception, where partners will change. You will have a different clinic instead of another one, et cetera. But those changes are a part of the entrepreneurial energy that we experience at Corbin Hill all the time. And that is at the foundation of food system and food system economics. We can't have one without the other. I think we really focus on food and nutrition, as we're working in that all the time as health institution and et cetera. But ultimately, where people's purchasing power goes is essential for the future of knowing where that local money is going, hopefully for local farmers and local institutions.
Thank you so much, Norma. My last question for both of you is, how can people advocate to see more of these programs in their communities in the future?
I can take a stab at that right quickly. Really participating in local governance and local community council groups. I just mentioned one of them. So if you have any interested community members who are a part of your clinics, or we're expanding beyond our actual food as medicine partners. So if you guys want to hear more about it or participate, based on the funding that we got through our innovation grant, we are providing stipends for any participant who is joining, because without you being at the foot of that table, then really we're relinquishing that power that we all have to people who might not really understand the full in-depth needs of our community and assets of those communities.
In one way that I think the team can participate is continue to apply. And this grant comes out on an annual basis. And people sometimes are scared. And Norma can tell, just provided the example of the community building that happens for doing it. So lean on each other. Like Norma mentioned, reach out to them, see how they do it. And you never know, you may have the opportunity to propose a certain or similar program within your community. So continue to apply, continue to have these programs available to your community, and provide your community members the opportunity to have access to fresh fruits and vegetables, or even whatever the overall goal of the project is. Thank you.
Thank you so much to both of our panelists, Dr. Jean and Norma. And I would be remiss if I didn't thank our team at Bronx Health Region. Kenny Escobar and Jamila Outlar. We have such great attendance, and they are so dedicated to the participants, and everyone is so grateful to have them. So thank you.